I think some of the exciting data that came out at ESMO was surrounding antibody-drug conjugates. We had data that was presented on TROPiCS-02, which was the randomized Phase III comparing Sacituzumab govitecan to chemotherapy, a physician's choice in patients with pretreated metastatic hormone receptor positive breast cancer. We had already seen data at ASCO that demonstrated a progression-free survival benefit for Sacituzumab, but now at ESMO, we actually saw a statistically significant improvement in overall survival with a delta between the two arms of a little over 3 months. And so to me, this does suggest that Sacituzumab can be a standard approach for our patients who have pretreated hormone receptor positive disease. So really nice to have another option for these patients who, unfortunately have limited treatment opportunities in that setting. I think the other exciting data that came out was surrounding overall survival from MONARCH 3, so data looking at CDK4/6 inhibitors. I think this was so relevant because currently we feel a little bit confused about how to select CDK4/6 inhibitors for our patients. We have 3 of them, and we had data at ASCO that unfortunately did not show a statistical significance in terms of overall survival for Palbociclib in the Paloma-2 study. And this was very different from data that we've seen with ribociclib, where there has been survival benefit from the Mona Lisa series of trials. And we had seen data with Abemaciclib with survival benefit in the pretreated setting, but we were awaiting the data for overall survival in the upfront setting. And so when seeing the MONARCH 3 data, this was a second interim analysis for overall survival, which did not technically meet statistical significance, but did show a 12.8-month improvement in overall survival in the ITT population. And when you looked at the visceral metastasis population, there was a 16-month difference between the two arms. And so to me, that's really very clinically meaningful. And it suggests that, we have choice of CDK4/6 inhibition, which is really nice because it allows us to individualize the choice to that patient. So we can look at toxicity profiles and individual patient comorbidities to make that decision. But I think, for many patients, ribociclib may be the appropriate choice right now, given it's the only one with technical survival benefit. But for someone maybe with extensive visceral metastasis, I tend to choose Abemaciclib, and maybe a more older, frail patient where you're concerned about potential toxicity from agents, Palbociclib may be appropriate. So, I think it's really nice to be able to customize this decision with these choices available.